now. Perfect. All right, I will toss it over to Dr. Spencer then. I don't know if we wanted to give some introductions.
Yeah, okay. This is Dr. Kevin Spencer out of the Dallas area. He's here to help us from Illinois to set up our program here. He is a physician, primary care physician, family practice, and he went through this same journey that we're going through now. He did his about 4 years ago, 5 years ago.
In our fourth year, yeah.
Fourth year. Going starting from ground zero where we're at, so a burden of illness, and then more things to come. Today is pretty much all burden of illness, which comes from our physician medical record reviews. And not to forget our APPs, we have 2 APPs here. You introduce yourself.
I'm Julie Thomas.
Hey, Drew.
Stacey Marco.
Stacey.
And you know Dr. Leticia.
Yep.
Okay, and Dr. Anteel.
And
with that, I can turn.
we've got one more right around.
Oh, we lost her.
No,
We have Grider and
got Jessica Sessom, Dr. Grider, and Dr. Pishardi
Very good.
on line 2. And then Nicole, do y'all want to do introductions for you and Michelle?
Sure, I will. I can go first. I'm Nicole Thorson, and I am the BOI manager for Pinehurst.
Hi, I'm Michelle Nelson, and I'm one of the directors on the market team for risk adjustment programs, and I'll be working closely with Nicole throughout your implementation. And I live in Raleigh, so I'm just right up the road.
Yep, yes, and I'm in Wilmington. Just got to travel to Pinehurst for my first time ever on Thursday. It is absolutely beautiful, so we are looking for any excuse to make a trip back. Time.
You guys have never heard that, right?
And I hear you have a golf course or 2.
I heard something about that. Weird.
Well, good. Nicole, are we ready to get started in the interest of time?
Yes, sir. Can you guys see our screen here?
Yes.
Yep.
Perfect. So you just tell me, Dr. Spencer, whenever you'd like me to change the slide, and I will do so.
That'll be great. As I speak, I'll just say advance, and then you can advance it.
You got it.
Kevin, the floor is yours.
All right. Let Melissa. Well, good. So what we'll do today is, just to give you an overview, is here at the beginning, we'll go through a very quick set of slides, just real fast, to orient us on what population health is and why we're doing the program overall, just as an underlying why. We're then going to kind of outline the PMRR program kind of operationally, just to show you how does it work, what are we looking for. Then we'll take a bit of a deeper dive into some of the specific codes and conditions that, as you review charts, that you're kind of being cognizant of. And then after we go through that, Nicole will take over, and we're going to leave you with a set of resources that you'll have as chart reviewers. And then she's going to take you through the database, the Agilon database called Core. So you'll learn, how do I log into this database? So when I've done a chart review and I found some extra conditions, how do I literally put that in so that when the doctor or APP that the wellness visit prints that form out, it has all of your documentation that you added as potential other conditions that the patient has. So she'll take you through kind of the technology piece briefly. Nicole will go over this at the end, but coming out of this meeting, today's meeting is really just a big overview for you to absorb. Dr. Doherty out of Wilmington is gonna along with Nicole, will then have a subsequent shorter meeting with you that will take you through kind of methodically how we methodically review charts. We've kind of come up with a way where there's 7, we call them zones. So when you pick up a chart, you're like, okay, I'm going to do the lab section. Here's what I'm looking for in labs. Okay, I'm going to do specialist notes, and here's what I'm looking for. Dr. Doherty will take you through that. So that'll be a little bit more of the meats and potatoes. Today is more like, in general, what are we looking for? How do we think about HCC categories? How do we think about HCC codes? What are the common things in a primary care note that we're going to find? So you're oriented, so then when you do that more specific training, you'll really pretty much coming out of that, you'll be ready to start reviewing charts. So as we know with population health, if you look at this graph, 30% of things come from genetics, 20% are from the environment. Sometimes we can change the environment. 40% are from patients' personal behavior. Sometimes we can affect that. And so really the 10% that's within healthcare that we do is only 10% of everything. So it's a very important 10%, but just kind of orienting how we think about that. Next slide. So next slide. So the kind of things that we can do are, as we think about this, there's primary care, there's hospital care, and then there's end-of-life care. So these are just some examples of different things that we've developed in different markets around the country. You guys may have some of these things going on. Extensivist care centers, think of that as like an urgent care on steroids where you can monitor people all day. Outpatient care programs, nursing care management, transition to care coming out of the hospital, strategies for keeping people who don't need to be in the ER out, hot spotting, looking at our high-risk patients, palliative care, hospice. So these are the sorts of things we begin to think about instead of just waiting for our patients to call us and come in, that we have a programmatic approach to them. Next slide. So, in the Agilon model, what you guys have now formed a partnership around, just to make sure people kind of begin to understand the way the business works. So in a traditional fee-for-service model, basically the government pays the health plan. Sometimes the patient has some responsibility that they pay a premium to sign up for insurance. The health plan gets all of that money from the government, and then the health plan will pay for everything they need. If they go to the hospital, they go to the doctor, get DME, and then whatever money's left, the health plan. And your part of getting paid in that is just whenever you guys do something in your office, then you get paid, and that's kind of the way that works. Next slide. When we go into the full risk model, things become more important. So in a full risk model, that health plan is then going to pay the Pinehurst Medical Clinic joint venture with Agilon. They're going to keep 10 or 15% of the entire premium, and then they're going to give the joint venture the rest of the money. And then we're a little bit acting kind of like the insurance company. Then we pay for everything, and whatever is left at the end, we split that 50-50. And so just beginning to think about, we now have responsibility of the dollar. For anyone who hasn't heard the debt, don't worry. Pinehurst Medical Clinic is not responsible for any financial losses. I just want to say that. I don't want to scare someone who hasn't been close to it. But these things become important. Attribution. So how do we know which patients on the Medicare Advantage plans are your patients? So we've got a whole program around that. Mostly if they're seeing you for primary care, they're your patients. Next is burden of illness. So making sure today what we're going to talk about, that we document the conditions that the patients really have. That allows us to know how sick the patients are for real. We put them in the right programs. It also allows the health plan to get the right amount from Medicare for how sick the people are. Quality. So the STARS programs are very important. So that, and then patient satisfaction and provider satisfaction is something we pay a lot of attention to in order to continue to make this better and better. Next slide. So first, an attribution. So basically, an HMO patient, they sign up and they name the PC. You guys are not a heavy HMO market. About 28% of your Medicare Advantage patients are HMO, but they actually sign up and put a provider down, and that automatically makes them part of the. In the PPO, where they don't absolutely have to pick it, there's logic that if you've been seen by primary care physician for the predominance of your care, then all of a sudden you will attribute to this model. You have to be seen in outpatient visits. So it's outpatient visits, wellness visits. Wellness visits count for more points in the attribution logic. So if you do the wellness visit, you pretty much have attributed that patient. They figure if a patient's going to get a wellness visit with you, they really consider you to be the doctor's office. If more than one patient sees the PCP, it's whoever gives the preponderance of care is a good way to. You guys have about 60% of the Medicare Advantage patients as part of your clinic in the entire market, the surrounding today. Next.
Hey, Nicole, do you have the ability to mute everybody? There's some background noise.
I believe so. I will give it a try. And I will go to the next slide for you too, Dr. Spencer. I'll give that a try.
And then this is where we're landing today, is on burden of illness. So again, Medicare knows that, you know, one patient might cost $10,000 a year that they're going to budget for that patient because they don't have much wrong with them. Another patient who has end-stage renal disease, they may need a budget $60,000 or $70,000 a year. Well, the way they know how much to budget is based upon the ICD-10 codes that got sent in from the year before. And so there's a set of codes called HCC codes that risk adjust. So they basically take the amount of revenue that they're budgeting for these patients. And so what we want to do is make sure we're being thorough in our documentation so that our new business model gets funded with the appropriate amount. We also, as you'll hear in this presentation, are very careful that what we're not doing is trying to in any way game that system. It's only the legitimate conditions that the patient really has, and we think about that a lot. So again, it's used to help resource utilization. It's based upon the codes from the previous year. It determines the financial needs for the patient's care. And it's very important because as this business takes off, you will begin to see that we're going to be able to provide a lot more services for our patients. But the amount of services is in some way dependent upon us doing this well and getting the resources. Next slide. Next slide. So the way CMS does this is the patient's age and sex gives them a certain score. If they're in an institution, that automatically adds a lot. So if they're in a nursing home or an assisted living environment, that really increases their score. If they're disabled, it really increases their score. And then the final thing is the thing we're going to talk about today, is the different diagnoses they have and the different interactions between some of those diagnoses further increases the score. So that's the way that risk score is calculated by the government. Next slide. So there's over 80,000 ICD-10 codes. There's about 8,000 codes that risk adjust. There's about 190 different categories, and there's 79 different hierarchies. Now that sounds really big, but I think after today you're going to see that, you know, many of these have been boiled down into what are we looking for in primary care, into a much more finite set of conditions that we're looking for. Next slide. So it's worth repeating that, you know, this is based on any provider's billing. What that means is if it's an APP or a doctor, if you see the patient for an encounter and then you bill their insurance company or Medicare, that is the conditions that come in. You know, we'll talk today that you can't just put the condition down because they have it. You actually have to document in a way that where you support that, meaning that you showed you managed it. The condition is stable, monitoring their blood pressure. You have to say something. It must be done on a face-to-face encounter. That does include telehealth, but it has to be that you get them on video. It can't be just a telephone visit. And then it's identified by certain specific ICD-10 codes that we call HCC codes, and it must reflect their current conditions. So if you have a patient with breast cancer and they've been cured and they're not on any sort of hormonal therapy or getting any treatment anymore, then you should no longer call them breast cancer, you should call them history of breast cancer. So these are their current conditions. Next slide. What is a hierarchy? Next slide. So hierarchy is just a way that as you get deeper and deeper into a certain category, this is where we're beginning to document the condition in the most specific way possible, often increases the score. So you see that coronary artery disease does not even risk adjust at all. angina risk adjusts to 0.13, unstable angina or an acute MI goes up to 0.195. So as you can imagine, there's different degrees of severity, and that's the hierarchy. Next slide. So here's another one. You know, the amputation status, if they have a skin ulcer on top of their stump, do they have vascular disease? So all of these are within a hierarchy. And so within any one hierarchy, with a few exceptions, and there's not many, but a few exceptions, which we'll talk about today, basically you can only get one score within the entire hierarchy. So therefore, if you chose to just put one of the lower, less specific conditions, you're missing out on something higher up in the hierarchy. So that's part of what the physician and provider medical record review team is designed to do, is to make sure we are showing our clinicians which are the most specific things that the patient really has so that they can document it. Next slide. So here's an example. So you have a 74-year-old male. So their risk score, just based on their age and sex, is 0.379. They're independently living, so nothing there. They're not disabled, nothing there. But they have diabetes with renal disease, stable angina, COPD, peripheral vascular disease, and hemiplegia from an old stroke. So now their RAF score went from only 0.379 up to 2.238. So literally the amount of revenue that they would give for this patient is, you know, 7-8-fold off of those conditions being diagnosed. Next slide. So here's our process, just real quick, as we think about the entire burden of illness. So on the left there, we're going to identify our members. So Nicole and team will be working with Melissa and Brandon, Dr. Daly, and all of you guys. We'll know, you'll get a report that says this is how many patients you have. You have 214 of these. So we're going to know who your patients are. We'll have a system where you chart reviewers will get sent out a list for that week of the charts that you're to review that week. And then what we'll learn today is you'll do that review. You'll get into this portal and you'll put your findings, if there are any, into the portal ahead of the annual wellness visits. Okay, so we will actually absorb your appointments file out of your EMR. So we'll know, okay, next week there's about, 28 wellness visits coming in. Okay, let's divvy out the charts to the chart reviewers a week or two ahead of time. And then you will do the chart review so that when the wellness visit is coming, they'll already have had that done. So the visit is scheduled. The provider does the visit. You will print the MIP form, what we call a MIP form, a member information profile form. That's just a form in the database that probably your staff will do for you. And you'll have that available to you at the visit that shows all the conditions they've had before, and then any suspected conditions that you chart reviewers put in. You do the visit, you do the appropriate documentation. Right after that's done, we have a certified coder look at it because we want to be compliant. So let's say if you put peripheral vascular disease and you said nothing about it, our coder would ping you and go, you got to show you manage this. I mean, continue aggressive risk factor control, continue aspirin and statin, something that simple. So we make sure it meets compliance. And then through that, we periodically, through the pod leaders, will give provider feedback. Like, hey, you keep missing this when you're doing it. Here's some feedback. Here's an example of your note. And again, Nicole's team tees all that up for the pod leaders. So when you go and talk to your docs, you're not the one trying to run reports. You get the information handed to you so that you're ready to go do that. So that's the entire process. And so the goal will be that we get 90% of your Medicare Advantage population, those 8,000 or 9,000 patients, that we're going to have 90% of them go through this process this calendar year. So that by all the ICD-10s being appropriately put through this year by your organization, when you go into the full risk in January of next year, we're going to be being paid the appropriate amount of revenue to take care of all those patients for that year. Next slide. So a little bit about compliance, we've touched on a little bit. So when we diagnose a condition, and you guys probably already do this well anyway, but again, we have to show that we're actively managing the condition. They can have breast cancer, and you can say, seeing the oncologist, undergoing chemotherapy. I mean, you don't personally have to be managing it, but you have to show that you have discussed it and that you're doing something with it, and that something like active breast cancer affects the rest of the way you take care of that patient. So by noting that and saying what's happening at the oncologist in a very brief statement is important. Things like, you don't have to do all of these, but these are examples of showing that you managed it, discussing their medicines, managing their medicines, discussing that you're making a referral, that you're going to do testing, labs or imaging, and the status of the condition. Is it stable? Is it worsening? You need them to come back. Those are examples. Again, it can be very brief, but to show that we're managing a condition. Next slide. So here's what the coders do in their review. They take that single progress note and they make sure that every condition that you put in supports it. So for an example, diabetes with hyperglycemia. Well, if their A1C is 6.1 and all their sugars look normal, they're going to probably ping you and go, why is it uncontrolled? You know, they only get information. So that's another thing. They can't look back at other parts of the chart. Like if you're going to put the code in that day, within that progress node, there needs to be some documentation about it. It does need to show that it's being managed. And they also help us with conflicting documentation. So for instance, we'll have providers go, in their HPI, they may say, patients coming in for well-controlled diabetes, and then lo and behold, in their assessment plan, they're saying diabetes with hyperglycemia, and it's like, that doesn't make sense. Or there's something in your review of systems that is negative, but it's positive in your HPI. They help clean that up for us on these Medicare notes. You know, that's not to say we never make a mistake, right? But in a commercial insurance plan where we're not at full risk, if we make that mistake, it's not tied to revenue and no one really cares. Now that we're in the risk business on Medicare, and this can lead to more dollars that the organization is managing, the audit process could be different. So we're just pretty tight and careful on that at giving quick feedback. Most of the time, that's not a lot. So most of your providers aren't having any trouble today. The ones that you guys can think of in your organization that already have trouble, they're going to have trouble, and we'll help them get at least their Medicare notes right. Next slide. So here's an example of the member information profile form. Next slide. First, let me tell you what's on it. So it'll have what disease categories this patient has, what hierarchy and chronic conditions have been done before. It'll also tell you which providers have put through those codes. So you'll be able to see, oh, the specialist put through that one, or this one happened when they were admitted at the hospital. And this is nice. So other burden of illness programs that I've seen, you know, they'll tell you stable angina, unstable angina, because it's come through at different times. You as the chart reviewers help us, and we clean all that up. So when you're the provider seeing the patient, there's no reason to have 9 things in one category when only one of them is going to, quote, count, right? So we clean that MIP up and make it as simplified as possible for our providers. So that's another important thing that we're able to do. Next slide. So here's an example of the member information profile. And so this will be just a form that you guys get used to seeing when you're doing the exams. It'll also be a form that you get used to seeing within the database you'll get in. So on this form up top, you know, we have the patient's name, when's their next visit, who's their PCP. You'll see that there's a PCP and then there's an SCP. The PCP is who the health plan says the primary care provider is. Sometimes, if you guys haven't figured it out, health plans are not always all that accurate in their data. So a lot of times they're telling you one person's a PCP, but lo and behold, we go into the EMR and it's somebody else. So all of our reporting to give the pod leaders will be based upon the SCP, because we're going to give it to you guys as who your EMR says the doctor or provider is. Next, this is just this historically significant and chronic disease profile. There's really nothing to do here. This just automatically populates based on the ICD-10 codes and just gives a quick snapshot about that patient. I just want to know what kind of things does this patient have? The next section called known chronic conditions. These are all the ICD-10 codes that risk adjust for the last 2 or 3 years that have ever been put through by any provider. With the thought being that most chronic conditions don't go away, so if this has been diagnosed before, the provider would have the ability to disagree with this, okay, and say, disagree. So we will have a mechanism to get the MIP form back so that if you guys disagree with some of these, we will take it out of the database so that the next time that patient comes in, you won't have to see that again because you've already disagreed with it. So you have your known conditions that you need to address. Then the next, this is what you guys as chart reviewers will add is the reviewer suggestions. So when you find things in the chart, you're going to put it there. So examples are, I found thrombocytopenia, recurrent or not
Other direction, low.
high thrombocytopenia, so the elevated platelet levels. Now we're gonna teach you guys that really you'll want to put elevated platelet levels, and then you'll want to put the date of the lab, so that way the provider knows where you found it, so that way they trust what we're putting in there. There's education. Instead of a code, you're going to put in an education comment. It looks like this person is no longer treated for prostate cancer. I would suggest that you call this history of prostate cancer. You know, they found depression, they found atherosclerosis of the aorta, and then down below just gives the provider a quick update on did they see other providers or a specialist. So this is family medicine, but it's different than the primary care. So it just lets you know quickly who else is seeing your patient. So that's what's on the MIP form.
So these don't include like HCC, but these are all codes.
It includes, that's a great question. Her question was, does this include only HCCs or does it include other codes? It includes probably 90% only HCCs because that's really the most important thing from the business model perspective. However, from a compliance standpoint, we do not want Medicare to say, you guys are only bubbling up only HCCs for people. There are other conditions that are important. So we put a few other conditions that are important in there, like hypertension and hyperlipidemia. Neither of those risk adjust, but to be compliant, but not very many. So we got with the compliance officers and said, we don't want to give them 58 things to look at. So how many do we have to put in there? And we put a few, but not very many. It's a good question. Next slide. Next slide. So sort of the goals, now we're going to get into a little bit of the real meat of what we're going to talk about. So the goals are for us, by doing a chart review, we can greatly improve the documentation. There's a lot of meat and different things in these charts that are in there that when we think about it, we can improve. And it's going to help us accurately reflect the disease burden. It also allows us to clean things up. So as an organization, you guys are going to decide how you want to do this. But if you see things on people's problem list that the patient no longer has or doesn't have, or if you see like hyperlipidemia, hypercholesterolemia, something else, then you don't really need all of those on the problem list. You can just pick the one that provider likes best. So there's ways that we can make the charts look more accurate. You know, this process, you guys will become pretty expert at this pretty quickly, and you will be the resources in the organization when people have questions that they can reach out to you. You know, this also gives us a chance when we build care management resources, or if you guys already have those, you know, as a chart reviewer, if you see someone who's not in care management and you're like, good gracious, this person's sick and they've gone to the ER a ton, that will be another thing you might suggest to the PCP or the provider. And then, you know, these recommendations, you're going to save some people clinically, right? You're going to find something in the chart like, wow, that dilated aorta never got followed up on. I see the doctor ordered the echo, but the patient didn't go, and no one's caught that. And it's been 2 or 3 years because, you know, we don't all read our charts back 2 or 3 or 4 years necessarily. So you're going to find things that improve the patients clinically as well. Next slide. So an example, here's a 76-year-old female who meets with her physician for the first visit in in 2013, she left her Ohio PCP. Next slide. So things we begin to think about in this patient, the smoking history. She probably had COPD in 2013 because we see a smoking history. So one thing we might do is, if they've never had PFTs, is suggest that. Maybe she has a diagnosed COPD that's undiagnosed. You know, we see a non-healing leg or ulcer wound in a smoker. We'll suggest, you know, peripheral vascular disease. Hey, maybe that's never been diagnosed. It's not on the problem list. We notice looking at the chart that her weight's trending down. We may look for protein calorie malnutrition, and we'll talk to you a little bit about what's the definition of that. So you guys will know the definitions of some of these codes on when to suggest them. You know, she's got anxiety. A lot of times it's really depression. So should they have depression screening? We think about kidney disease, looking at their labs. You know, we think about the management of their conditions. You know, she's got some shortness of breath noted. Maybe that's COPD, maybe it's something else. And so these are just some of the things we might begin to think about. One is we begin to think about it if it's never been looked at, but a lot of times these are the things you're going to go look for. Like, oh, where's that last echo? Where's the chest X-ray? You know, where's the last set of labs? And again, Dr. Dockery will talk you through how to systematically. So you'll just get into a real system where you go through these 7 zones of reviewing a chart, and it'll just become second nature. Next slide. So again, using the most significant code, the most specific code becomes important because of the hierarchy. Some of the things we see, you know, one is it needs to be supported in the medical record. So as you guys are reviewing the chart, you may have a clinical instinct to say, I think this person might have this, but you don't want to suggest a code if it's not in the medical chart. You know, you guys as clinicians will begin to, with your own patients, start to think, I bet this person has that. I don't think it's going to greatly change my management, but it's a risk adjustment code. They really have it. I'm gonna start to diagnose that. Things like diabetes with neuropathy. You might not have been so keen to write that in your note, even if they have it. If you're like, I'm going to do the same thing with their overall diabetes management, no matter what. So why do I have to put that? But the specificity is important. You know, we're talking about, you know, the cancers, they have to have active cancer. You know, it further risks adjusts when they have active cancer to talk about the metastatic bed of where that cancer is metastatic to. So that'll be something you'll be suggesting to providers when you see their oncology notes. You know, it is okay for things to be in the inpatient medical record or outpatient medical record, right? So if they had labs from when they were in the hospital that show you they have thrombocytopenia, you can count that lab even though it hadn't been, you know, repeated yet as an outpatient. So those are things that you know you want to do. Whenever we're suggesting a code, like I said, we're going to train you guys to tell the provider where you found it. You know, echo from October 17, dilated aorta. That way that provider can quickly go find that and they're not having to search through the record. Next slide. These are the different things that you guys will do. So probably 90% of what you do is you're going to put an ICD-10 code in that you found, and you're going to tell them where you found it, and it's going to be a suggested code. But when other things come up, we've got a little nomenclature we use that everyone gets used to. So REC stands for recommendation. So we've started training our chart reviewers to do certain kinds of recommendations. They've got a 20+ pack years history of smoking and they've never had PFTs. Let's recommend it. They've got CKD4 and they've never had a parathyroid hormone checked ever before for hyperparathyroidism, renal disease. Let's check a PTH. There's not a ton of those that we put on you guys, or you just find something that you're like, oh no, there's a PSA from 2015 of 10 and no one's repeated it yet. So you got that's where you would be putting in a recommendation. An EDU is an education. So this is one where you just kind of want to clarify. You know, the problem list says bipolar disorder, but you're putting in your notes depression all the time. You know, I'm not sure what she has. You may want to follow up on that. ADX stands for additional diagnosis within the same category. So if you remember, I said if we have a whole bunch of things in the same category, we pick the most specific one and leave only that one in because that's the one that we want the provider to get. There are a few exceptions. So for instance, diabetes with neuropathy plus diabetes with retinopathy, if you put both of those in the same note, you're not getting additional risk adjustment. But we tend to leave certain diabetes codes in because one was we think it's important clinically, and then there's some exceptions within diabetes. So you will get extra risk adjustment if you have diabetes with peripheral vascular disease, even if you have diabetes with neuropathy, diabetes with retinopathy, diabetes with hyperglycemia. So that one is additive. Diabetes with proliferative retinopathy is also additive. Diabetes with a diabetic ulcer is also additive. So there's times where we actually don't want everything erased in the whole HCC category. So these ADXs, and there's literally like 5 of those that you guys will quickly memorize, and then you'll know, okay, I'm going to ADX this one so that it doesn't suppress it, because I want that code to stay in there. Sometimes people want to know, well, maybe I didn't get my chart reviewed. So, you know, like in Austin, Texas, 32% of our patients have 0 HCC codes. So everyone doesn't have one, right? You have well patients too. So we put none when that happens, just so they know you actually did review the chart, okay? NOR, this is where you get a new patient who moved in from out of town or just established care, and you haven't gotten the old medical records yet. So you're basically telling the provider, it's really important you get records. And then we have a system where we come back to these NORs once the records come in and send it back to one of you reviewers to go through the old records and get that all beefed up. And then we've got certain things that we started to really think about because we just had low prevalence in some of these conditions. So tracking CHF, so there's certain things where, you know, you'll want to make sure on a few disease states, if the clinicians have not done some follow-up testing or they don't have optimized treatment plans, you know, and we're careful with this. You don't use this very often, but, you know, if you saw someone with CHF and they're not on an ACE and they're not allergic to an ACE, and you look at their labs and they don't have hyperkalemia, you might be going, I wonder why they're not on an ACE. And again, the clinician may have a great reason they're not on an ACE, so no one's going to get offended if you go, hey, tracking CHF, notice this person's not on an ACE. You know, you're just telling your colleague, I noticed this, I can't tell from your chart. I'm sure you got a good reason for it potentially, or maybe they don't and they just overlooked it. Next slide. So these are just some other things that we track. So tracking osteoporosis, since this is a STAR measure, you know, we just noticed that it was common for our providers to not always be diagnosing this formally, even though they might mention it in some ways in the chart. You know, radiology findings, it just lets people know, you know, hey, this is an important one, you repeat this lung nodule. And then end-stage renal disease, we have all of our end-stage renal diseases patients in our market followed by care management to help make sure they're compliant with their dialysis appointments. So if there's something that we want to tell them, again, a lot of times you're not going to be using these memos. You're mostly going to be finding ICD-10 codes within the documentation that you're suggesting. But these things come up, and this is just our nomenclature that the docs and the providers get used to hearing from us. Next slide. All right, next slide. So here's sort of some of the ways we think about going through it within each disease category. So in renal disease, the main things that risk adjust is CKD 3 and worse, end-stage renal disease, and then more acute codes that happen in the hospital where you have more of an acute kidney failure or you have a renal infarct. So the way I like to train this, or I like to think about this, is through the filter of kind of within each organ system of the body, what's the kind of stuff that risk adjusts? And you'll quickly pick up on, you know, basically within each organ system, it's the worst stuff. And so that's what you're looking for. So primarily, you're looking for labs, sometimes imaging studies, but mostly labs. Next slide. So you guys are likely very familiar with staging kidney disease. So again, the ones that risk adjust are stages 3 or worse. Some markets are wanting to note to the provider stage 3A versus 3B. You guys can decide how you want to do that, whether you want to go that specific. There's no value there from a risk adjustment standpoint, but sometimes, you know, you may be not referring to the nephrologist until they're 3B. So if y'all have a system like that, then knowing 3B might be helpful to your clinicians. But these are the things that we look for. You know, we will be training kind of some of the specifics, like, well, if they had a GFR of 58 and then a month later they had a GFR of 61, is that still CKD3? And the answer is no, right? It's persistent, 2 different lab values, persistent for 3 months. So those are rules that you'll know what are the exact rules to call something CKD3, especially as an example. Next slide. This is just more staging, you know, just you're seeing the GFRs hop around, right? So you can see that over time, within this 1 year, this patient went back into 2 and back into 3, and so you know, this is kind of that exact scenario I just mentioned. So you'll be trained on when to call it what it is. What's interesting is if, you know, from a risk adjustment standpoint, if they were 3 one time in that year, then you're gonna get that for the next year if they just have. But that's why you want to look for it. Is you might be going, man, they were 2 most of the year, but they were 3 right here. And if you're about to do a visit on them and they're actually 3 at that time, it's important to get it. Next slide. So weight loss, you know, greater than 2% decrease of your body weight in 1 month, 5% in 3 months, 10% in 6 months. If you begin to see that, you begin to want to think about the diagnosis of protein calorie malnutrition. And so these are just some resources. Again, you know, you'll see things like their albumin level, their degree of weight loss on what meets the criteria, and then you will be able to suggest that to your provider. Next slide. Obesity is a big one. I don't know about the people who live in Pinehurst, but a lot of people in Texas are pretty big. So we were underdiagnosing this in our market. So I'll remind you, a BMI of 40 or greater. It's important to actually use code E66.01 as morbid obesity. The Z code for what their BMI does not risk adjust. It's actually this E code that risk adjusts. And anyone with a BMI 40 or greater meets the criteria of morbid obesity. Anybody with a BMI of 35 or greater who has any comorbid condition that in any way relates to weight. So that's basically anything. So I would say probably 90% of your people with a BMI of 35 qualify as morbidly obese, because almost all Medicare age people will have at least one of these things, okay? So you might as well begin to start thinking as you're reviewing charts and as you're seeing patients, if they're 35 or higher, I need to have a really good reason why I'm not diagnosing them as morbid obesity. You know, some of the things that you'll want to think about as an organization is as you start putting morbid obesity on their problem list more and more, and if patients can see their problem list on your portal, you can offend people, okay? So there are ways within the EHRs, and we'll talk to you guys about all scripts, where we can suppress certain conditions that don't get viewed on the portal. So there's ways to do that, just so we're not offending people when we don't need to.
Can we do that with Thursday now?
I think you can.
I don't think so.
You don't think we can?
Mm-mm. I think starting off. This is weight bearing osteoarthritis, so the next, there, it could, it says it's just like that. Or can we just say osteoarthritis of the hip?
They're listing things that.
Well, the other thing you can do, I mean, the other thing I've seen people do is they just change the verbiage from morbid obesity to something else that's just a little kinder, but you still leave it as code E66.01. So.
In our chart, there's class 2 obesity with comorbidity.
Mm-hmm.
And then, you know, so it's like 30 is going to be, and then it breaks off into 2 codes, the E6601, and then it goes BMI 35 to 36 or whatever, you have to pick one of those 5.
Yep.
And then I know that if they call for hypertension or call for osteoporosis.
And you don't get a lot of patient callbacks from that?
Because it just comes out as class 2, obesity.
Okay. Yeah, I mean, if you're not having any trouble today, you may not have any trouble, but I flagged that because we got some callbacks because all of a sudden, you know, we're looking for this and we're putting it in more and more. And, you know, honestly, if you got a BMI of 35, you probably may not think of yourself as all that overweight in our world today. I mean, anyway, it's just something to be aware of. But
I think we can look at all scopes because E6601 will have multiple like the same code is in there like 10 times with different verbiage.
You can pick the softest version.
Some of that.
I'm totally okay with putting morbid obesity.
I think we should take it really hard for that. I've had complaints.
Yeah, I mean, I think you guys could take, I mean, and I honestly, different people feel differently. I just think what's important is that we own what we're telling our patients they have. And if you say something like, hey, I think your knee pain and your back pain can get better if we work on your, and don't get caught up on the words. I mean, it's just a number. That's just what they call it. If you're higher than 35, they call it that. And so, you know, let's get you down to 34.9 and then we won't have that on there anymore. So, but you guys know how to handle that. Next slide.
That's what I told them. I encourage them to lose weight. And then when I take morbid obesity off of there, I let them watch me take it off.
That's cool.
You took it off your list. Don't be angry, I'll put it right there.
I love it. So, again, nutritional status is pretty important. We're just kind of showing you of some of the risk adjustment codes. You know, we don't get too deep into this, but if you look at how big the score is, a lot of them are in the 0.1. You saw some stuff in vascular disease that was like 0.13 to 0.19. Look what obesity and underweight is. It's super important. Depression is also another one. So when you think about, because these things affect so many other things, right? So if you're depressed and you're diabetic, all of a sudden your depression is leading to you doing worse than your diabetes. So they become very additive. So that's how all of this stuff by CMS, it's just an actuarial game. They're just like, the people who come in with these codes, they just cost us much money across the country. That's how they're thinking about it. We clinically may look at some of this, like for instance, coronary artery disease does not risk adjust. That's because it's not a differentiator in cost, because so many people over 65 have coronary artery disease, it's not a differentiator, right? But obesity, depression, so just, this is a big one, that's why we put it in here. Next slide. So within pulmonary disease, you know, again, you're thinking about each disease category. You know, a lot of the stuff that's more in the hospital, like, you know, respiratory failure as an example, but, you know, most COPD is your common one. Within asthma, it has to be chronic obstructive asthma, okay? Bronchiectasis, interstitial lung disease, your pulmonary fibroses, all of your mycoses from old infections, sarcoid, TB, any of those all risk adjust, okay? TB would need to be active TB, not a history of. The other one, I don't think we have it up here, but the other one that's kind of interesting is smoker's cough or simple chronic bronchitis is a risk adjustment code. So the way I think about it is, if you're a smoker, you either have already gotten into the place where you have COPD, or you're a smoker and you don't have COPD yet, but you cough, so you have simple chronic bronchitis. So a lot of smokers should probably have either simple chronic bronchitis or COPD. I mean, if you have a smoker who literally never, ever coughs, then that's fine. But as we all know, especially in your 60s and 70s, you usually are coughing. So that's an important one. Next slide.
This is a good place too to do the education about emergency screening. It's really not terribly consistent on that.
Right. So within cardiology, you know, ischemic cardiomyopathy is one. Again, plain old CAD does not risk adjust. You know, angina. So anybody on long-acting nitrates who's asymptomatic from Medicare's documentation purposes, they're considered to have stable angina. So that's why they're on the long-acting nitrate. So So, you know, looking for short-acting nitrate use intermittently, if they're not on that, would be another one. CHF, risk adjust. One of the things about CHF is considered permanent unless you have like myocarditis and you got completely well, which is usually a disease of younger people for the most part. But so if you have CHF and then all of a sudden they go back to the cardiologist and their ejection fraction gets up above 50% again, that's considered CHF well compensated. So once you have it, you always have it from Medicare's perspective. Arrhythmias, any AFib that's being treated, so they may have intermittent AFib, and so their EKG that day may be in a normal sinus rhythm. But if they have AFib and they're chronically anticoagulated because the cardiologist or you as the clinician think they could be going in and out, then that's still AFib. Different than AFib, they go have an ablation, they're in normal sinus rhythm, and they're never popping back into AFib. That's a history of AFib. So those are different. You know, any of your devices, the underlying reason, sick-situs syndrome, if they had VTAC, you know, all of those things are risk adjust in codes for cardiology. Next slide. So this is just pointing out the various heart failure stages. You know, again, CHF does risk adjust. Generally, it's C and D is when we actually begin to clinically make the diagnosis. Sometimes we do B, but mostly they're in C or D before we make the diagnosis. Next slide. So again, from an HCC perspective, they do need to be in stage C or worse. You know, we look for diuretics, echoes, hospitalizations for heart failure to see. I would say that most of the time, this is not one that our doctors don't have on their chart already, right? If you have CHF, you're sick enough, you got that. But you may notice things where there's some stage B and maybe there are starting to be some subtle symptoms you start to notice in the chart to review systems where you may want to suggest and recommend, hey, you know, they may need an echo. It looks like they're, you know, I see a couple of your notes where they've been short of breath and, you know, you blamed it on it was flu season, they had the flu or something else. It might be just a recommendation. Next slide. So vascular disease, this is a big one. In general, we have low prevalence in the Agilon market. So we've been working a lot on, you know, us being more thoughtful about peripheral vascular disease, because it's just not something, if they're not having leg pain, that you often, if you're already managing the risk factors aggressively anyway, you don't always think about it to get it on there. So carotid stenosis does not qualify. If you have thoracic or abdominal vascular disease or atherosclerosis noted commonly on CT scans or x-rays in the thorax or the abdomen, but not in the carotid. You know, we the radiologists, early in our market, we went to our radiologists and we said, we want you calling this all the time. We care about that now. So they started calling it all the time. So then we met with some compliance officers and said, it looks like our atherosclerosis of the aorta diagnosis is way high on the prevalence compared to other groups of the nation, and we want to be doing this ethically. What do you say? So they basically said, if you note very mild disease on a scan and it's just like an incidental, and if they use the words mild, then we don't add atherosclerosis of the aorta as a diagnosis. If it's moderate or severe, we do. And that pulled us back into, we're on the higher end, but we're not too high, and the Medicare people say we would pass an audit. So that's how we do that. Ectasia of the aorta is another one. You'll see that sometimes commented on in radiology studies. Venous stasis ulcers, DVTs, all of that risk adjusts.
Just for the record, our Allspitz program labels tortuous aorta as an HCC code for whatever reason. Have you seen that?
I didn't put that in there.
Anyway, they say it doesn't count, but it's labeled HCC in our Allscripts system, so maybe Nicole.
I think when he says it doesn't count, I think what he's saying is our recommendation from the compliance folks was that you need to see the words ectasia, not torturous, or you shouldn't suggest it to put it in there, because there's nothing clinically is my understanding. I'll write that down, Dr. Daly, and I'll get back to you on that. 'cause I
Yeah,
wanna-
the other thing, sometimes when you say community policy, if you actually look at the code, it actually is the same code as the ECHS. I mean.
Well, it's kicking it to a different code.
Right.
Michelle or Nicole, do you guys know the answer to that on tortuous aorta? Why we're saying that doesn't count? Is that not a risk adjustment code?
It is a risk adjustable code, but it was being used inappropriately, and within our coding guidelines document, the larger document that Nicole distributed, I believe there's some detail about that. We'll pull it up.
Yep.
Yeah.
And if there isn't detail in that document, we'll make sure to get it out to everybody. I did make a note of that.
So, but these are what you're doing, like what we're doing right now when we discuss stuff like that, that's exactly what you're gonna do at your bi-weekly 30-minute PMRR meeting. Like you guys will debate that, and then people like Michelle, Nicole, myself, Dr. Ambler, Dr. Kornitzer, it's our job when you guys come up with a question like, what's the guidance on this? Then that comes up, you guys shoot us an email and we go do the work for you and say, here's how you handle it. And so literally within a few months, you'd be surprised, like you guys are gonna know so much, you'll just know it. I mean, there's not as much of it as you think, but these little specific questions come up. Next slide. So this is just, again, you know, beginning to show you, so if there's something like an ulceration, look at the difference in the risk adjustment on that. I mean, it's gigantic, right? So once there's an ulceration, it's important. This goes back to the most specific code within a category that you guys will be trained to suggest. So, I mean, all of vascular disease is pretty important. Like, you know, the 0.383 is a pretty high risk adjustment. If you remember, obesity was like 0.25. So this is a big one. You know, there's a big debate that I'll just open this can of worms and you guys can debate it. And it's like, so different Agilon groups around the country have thought about peripheral vascular disease differently, right? And so we've had some groups begin to screen more and take all their 65 and olders who have diabetes or were a smoker or former smoker, and only that cohort who have a pretty high pretest likelihood. Now that's not yet an evidence-based guideline, right? Okay, really. So the problem could be, well, now we're identifying this, and now our providers are unintentionally referring on to the vascular surgeon, and we're increasing cost of care at no value to the patient. So we had to train and say, no, you know, you don't want to refer them to vascular surgeon unless they're actually having symptoms. And so what's the value in knowing besides revenue? Well, we found, some of the groups have found the value in knowing, much like a CT calcium score in a patient, is that it changes your conversation with the patient. When you've got a disease bed now, that smoking cessation conversation might go way differently. Their ability to take the diabetes medicines and want to be more compliant when they're starting to think their limb could be in trouble might be very different. So we think if the patient really has it, and honestly, some groups are in one camp and some groups are in another around the country, but these are the sorts of things that we all get to come together and debate. and your group gets to decide how you want to handle it, or each doctor or provider in your group gets to decide how they personally want to handle it with their patients. But these are the good, I think I call them good debates. I like the energy around us debating how do we think about our patients this way. Next slide. So in skin, there's not a ton in skin. You know, clearly if you had a patient with a burn, we've talked about pressure ulcers are huge, non-pressure ulcers, psoriatic arthritis. So there's not a ton in skin. There are a few other things, but like skin cancer, but not a lot. Next slide. Senile purpura is a good one. So we had one practice that started like, because if you look for it, like, well, I don't know, what 70% of patients probably have some, right? So that's another recommendation where we looked and got guidance from a compliance standpoint and said you should only put senile purpura if they have some sort of coagulopathy. If they have both, then that's fine. Like if they have thrombocytopenia, then you can use it. But anyway, that we had a group that was overdoing that because they were just calling everyone that. And you know, again, some of that is where we have to decide, like, how do we be pragmatic? Because you could say, well, bring on the audit. The patient's got it. I got a picture of it. But there's a pragmatism of, you know, we don't want to see ourselves having prevalence rates that are double, triple the national average. It just puts us on people's radar. It's not worth it, especially when, as providers, we're all like, that gives that patient no clinical value by putting phenylpurpura on the problem list. It's just not that important. So anyway, that's a good one that if they have anything bleeding wise or in their coagulopathy, then we should use it, but we shouldn't use it without that is our current learnings on that.
Does that count if they're on medicine, you know, aspirin, Plavix, oral anticoagulant?
Yeah. If they're on that, yeah. I mean, aspirin, you know, I think we have some guidance on that in this resource material. I don't know off the top of my head what we last put, but we'll show you that at the end. So some of these questions, when I told you at the beginning, we're going to leave you with some resources, like here's the categories that for you to have at your ready. Some of these, we've debated these for 4 years now, so a lot of these things we've already went and got guidance on. I just haven't committed all of them to memory. I have to look at my guide sometimes.
But we have dermatologists in the practice, and they're good about putting that there, but, you know, when I'm going through it, I'm on number 14 in the list, and I'm trying to document all the codes, I'm like, you know, really? So it would be helpful to know, because sometimes they feel like, am I really?
Yeah. We can get you that today. We'll get to the material in just a second. I just don't know off the top of my head. So in neurology is a big one. Like most everything in neurology risk adjusts. So if your patients have chronic neurologic issues, it's going to risk adjust. The big one that started this year is dementia. Dementia did not used to risk adjust, and now it does. So that's a big one. Next slide. So, like they said, dementia is in the payment model. I guess it was last year it started to risk adjust. So just thinking about your dementia screening, what you guys do, looking at the neurology and psychiatry notes. You know, some people were calling them mild cognitive impairment, and if they haven't been re-screened to see if they actually meet the criteria. Different markets use different screening tools, slums, MoCA, mini mental status, different ones are being used. I do know that several of the markets, and we started doing this in our practices, we started doing a mini cog as part of the annual wellness visit, where our medical assistant is trained to do a mini cog. That's where all they do is remembering the 3 words and draw the clock, because it gets them out of the room fast and it wasn't hurting our flow too bad. And then anyone who is 3 or worse, we don't necessarily tell them they have dementia, but then they would have them come in within 4 to 6 weeks and see their provider just for that. So that way we're not trying to do too much at an appointment. And so then you can potentially have a family member come, then you would maybe do a whole mini mental status and then decide. And then we've come up with an entire dementia workflow where we're trying to, what we don't want to do is diagnose dementia when it's mild to moderate and it looks like it's been slowly progressive, and all of a sudden they've got an MRI, an MRA, and a neurology consult. So we've looked at the literature, and the geriatricians have said really even RPR is no longer recommended as part of the workup. It's really just a B12 and a TSH. And then what we do is use clinical judgment on should we do a head CT, because that's $200, that's not that expensive. We could rule out tumor, we can see atrophy, we could see multi-infarcts, we could potentially see increased size of ventricles, make sure we're screened for normal pressure hydrocephalus in our history, but we don't do a lot to the patient. And then we're recommending exercise and some cognitive behavioral therapy if they like to get on apps or other things that they can do. And then we repeat it in 6 months. So we kind of came up with a clinical pathway. So we're starting to see our dementia prevalence go up a little bit, because we were way, way below the national average because we just weren't screened very aggressively in our group, as an example. So these are just things that really you guys will all decide as a group over time, you know, and like we talked about last time, you don't want to do like 9 things. If you're going to do anything besides BOI, it's probably one more thing, and that's it. Just because this will be enough, right, of a change management project this year. Next slide. Psychiatry is another one. bipolar, anorexia, schizophrenia, any psychoses. Personality disorders is a big one. Personally, we just don't pick that up very often unless they go to a therapist. But it is, so depression screening is important. Of course, that's part of the annual wellness visit. You know, if someone is on an antidepressant chronically, although that day you're not depressed, that is considered depression, major depression in remission, right? You're treating them. If you've had 3 or more major depression episodes in your life, but you're not on antidepressants right now and you're not depressed, you also are considered chronically depressed by Medicare. So you are major depression in remission, controlled off medications. So those are some things you guys will learn that you'll be able to suggest to your providers. Next slide. So again, major depression, making sure we all know that the criteria of that diagnosis is important. Most of us probably know that, but this is kind of the PHQ-9 screening questions that are in there, so y'all are very familiar. But again, this is just a really important one because it's a common thing among the elderly. Next slide. So musculoskeletal, not a lot in musculoskeletal except for acute stuff that happens. Sacroiliitis, you know, we had to start understanding the criteria of sacroiliitis. That'll be in your training manual as to what the exact criteria. Some of the radiologists are calling that, and you need to have more than just it on an x-ray to call it. And then everything autoimmune basically risk adjust. So almost everything in the field of rheumatology will risk adjust. So that's just something that you'll get used to. And you guys have rheumatologists who work with you, so you'll be picking. This will be one where, as the primary care, it's probably already been put in there by the rheumatologist for the year anyway. Next slide. So immunodeficiency. So any immunodeficient conditions, we'll go over this in your materials. Like if someone's on chronic prednisone by the rheumatologist, then you cannot call them immunodeficient for the purposes of this. Okay, if they're on a biologic from the rheumatologist, even though that does suppress their immune system, those are examples where you would not want to use this. You can use immunosuppression due to medication, but that code doesn't risk adjust. So in my mind, I don't know if you want to put that. I mean, most doctors are smart enough. If that doesn't risk adjust, then if they see they're on Humira, they already know. They don't need it on the problem list. So again, in the spirit of less is more, and if it's not really helping us, then you know that's the way to think about it. Next slide.
But does a high dose prednisone does count, doesn't it?
Possibly. Can you go back one, Nicole?
The first bullet toward the bottom of that first bullet. Other medicines on high dose corticosteroids or transplant recipients.
Yes, that's right. So like if you had someone with temporal arteritis and you had to put them on, yeah, then
okay.
If you had someone with polymyalgia rheumatica and they're on 5 milligrams a day and they're going to be on that for ever and ever, amen, then you don't do it. That's right. If it's in an acute setting where you had to go pretty high on your steroids, 60 or higher, then you can use it. Next slide. Which that's one a lot of our docs wouldn't pick up on. So that's a good one as a chart reviewer for you to see because they're just not going to think of that. So hematologic, you know, most of your hematologic conditions that are any sort of myelodysplastic syndrome risk adjust. Even if it's chemotherapy-induced cytopenia, that's still risk adjust. So you can neutropenia, thrombocytopenia, even if it's from chemotherapy, IgA deficiency, polycythemia, you know, any of your syndromes like lupus anticoagulant, antiphospholipid, all of those things risk adjust. So again, you're going to find all of this typically in your labs or maybe in a bone marrow biopsy when you're doing the chart review. Next slide. And then you know, cancers, they have to be active, otherwise they need to be history of is the big thing. But of course, any of those bone marrow hematologic cancers do risk adjust whenever they're being actively treated. Next slide. So dependence, abuse, and addiction. I think I told this story to some of you guys the other day, but so, you know, alcohol and drug dependence or addiction are really big ones, and they really risk adjust pretty significantly. So like CHF, Medicare considers once a addict or alcoholic, then always an addict or alcoholic, that it's a disease that people certainly get treatment and thankfully go into remission and change their lives. But so if you had someone who has a history of what we used to call alcoholism, you know, the appropriate diagnosis from a risk adjustment standpoint is alcohol dependence in remission, right? Or cocaine dependence in remission, or opioid in remission. So those are things. If you had people who had been to a drug treatment program or alcohol program or actively involved in AA and are kind of ongoing.
Do they risk adjust?
Yes,
They do risk.
that risk adjust. What we can't do is your patient who sees you or sees their specialist is on 60 Norco a month, and they've been on 60 Norco a month for 5 years in a row, and they never escalate their dose. Even if you think if you stopped it, they would withdraw. That's part of their treatment plan. So Medicare doesn't say that you should put opioid dependence for that patient. Now, similar to the way the GFRs hop around on kidney disease, let's say your person who's taking 60 a month comes in and they're 2 weeks early and they've used up all their medicine and they start escalating their dose and they did it without asking you, then you could say that and then say, hey, we need to get you back on the plan. And so they came off the plan. If they're coming off the plan and you're concerned about them, then you can say they're dependent until they're back on the plan and doing well again. Next slide. So again, alcoholism is either active or in remission. They have it. You know, the alcohol abuse or acute intoxication. So if a patient goes to the ER, that does not risk adjust. So what you want to be really reviewing there is, are you feeling like clinically, and this might be a recommendation to the provider who knows them best, but you might say, do you think they actually have alcohol dependence, or do you think they were binge drinking and overdid it? And again, a Medicare age person who ends up in an ER acutely intoxicated is highly likely to be an alcoholic, right? Your 20-year-old college student, maybe not. So just as you're thinking about, we're talking about Medicare age people, that's not that common unless they're really in trouble, usually. And you can look for other things that may give you a suggestion of alcoholism. Again, you guys are going to have already picked up on those things most of the time. Next slide. So just looking here at the significant amount of risk adjustment factor that we see from these substance diagnoses. Next slide. So the other one is both devices and device complications. Foleys themselves do not risk adjust, but if you see in the notes, breakdown, displacement, leakage, infection for an indwelling catheter, then that would risk adjust. You know, all your orthopedic device, your vascular grafts, all your stomas, your ostomies, all of those things risk adjust. They usually have Z codes, and you'll have a cheat sheet for those to look at. So you're looking at your hospital notes, your surgeon notes, and when you see that, we want to make sure we suggest those codes if they're not already being diagnosed. A lot of times, these are on the recapture one, so a lot of times we've already got them. It's in recapture, but sometimes you guys will find those, especially if it's new. Next slide. Again, all of your ostomies risk adjust, and we need to document them every year if they end up having these year over year. Next slide. And look at that risk adjustment factor. Those artificial openings are very, very, very high risk score. Next slide. You guys have heard this a gazillion times. Amputations, everyone makes the joke that it grows back every year, yada, yada, yada. Y'all know that, so. Next slide. You know, it's pretty significant score. Next slide. So infectious diseases, a lot of these are done in the hospital. Occasionally you may do these, but you know, lobar pneumonia, aspiration pneumonia, if you can diagnose them, you get a bug. So occasionally you can actually get a bug as an outpatient. You really, you know, to use the very specific code of bacterial pneumonia, you need to probably gotten a blood culture and found a bug. But those things are usually going to happen in an inpatient setting. Next slide. So cancers, we, you know, looking at the pathology report, making sure we've got the correct cancer. You know, again, the secondary metastatic beds and noting where those are. If it's no longer there, switching it to history of. So especially for breast and prostate cancer, you know, where they get on prolonged therapies with Lupron or tamoxifen or some of the other drugs that they're on sometimes for up to 10 years. If they're still on those medicines, it's still considered active cancer. So the whole time they're on that, it is considered active cancer. You know, if they had metastatic cancer, but, you know, it looks like the chemotherapy took care of it, but they're still going and getting imaged, if they have a history of metastatic cancer, they have active cancer until the 10-year mark. If it doesn't come back at 10 years, then you can stop doing it. So those are in some of our supplemental data around cancer, because that'll be a big one. Where we really, of course, most people who have cancer, someone's putting a diagnosis in. Where we help ourselves are the people who are breast cancer and prostate cancer patients long term. Sometimes people stop putting it in every year, and then the metastatic beds where the metastatic cancer went to. Those are the big ones that the chart reviewers are able to help.
Yeah. Kevin, do you know how they do the people with prostate or breast who are recommended to be on something for 10 years, but after 2 or 3 years refuse it?
Then they still have active cancer.
For that 10-year period.
Mm-hmm. Yeah. Next slide. So these are, you know, we'll give you a cheat sheet a little bit on how, you know, which codes you put for the secondary metastatic beds, but you just look up real quick where they are, and then you put C77.1 in, et cetera. So that's just an important thing that adds more to the risk score. Next slide. I think we see this a lot just because, you know, before we were in the risk business, whether you said prostate cancer or history of prostate cancer wasn't that big a deal, but now it is. So we just kind of hammer that you don't want to be putting in cancer if they don't really have cancer. So that's really the purpose of this slide is to, and you're going to help your providers because you'll have an EDU that you'll put in there saying, you know, this is really looks like a history of cancer, not active cancer. Next slide. Again, just kind of beginning to show that, you know, the difference between metastatic and non-metastatic cancer is pretty significant, right? Look at how little breast and prostate risk adjust, right? Again, because once you're in that Medicare age, it's not as differentiating because so many people have it that it's not as differentiating. Next slide. Within GI, esophageal varices, pancreatitis is a big one, portal hypertension, hepatic failure, hepatorenal syndrome. These are all big important conditions because GI doesn't have a whole lot outside of this plus inflammatory bowel disease. Next slide. You know, chronic hepatitis, it can't be NASH, and they have to still have active disease. So now that we have a lot of our hep C's getting cured, if they've been fully cured, then it's history of. You know, cirrhosis is definitely important, inflammatory bowel disease. Again, some of these other conditions that are more acute that you see in a hospital setting or ER setting with intestinal obstructions, ileus, fecal impaction. Next slide. Good old diabetes. Next. So, you know, the way we talk about it is if a person has CKD and diabetes, then we train to diagnose that as diabetes with CKD3. It's more, you get more documentation wrap for doing it that way. So we believe that most 65-year-old diabetics have a complication by the time they're that old. You know, typically you've had diabetes from when you're past a decade with diabetes, you often will have at least one complication. We actually show our providers, here's how many diabetics you have in your panel, and here's what percentage have complications, just so they start to begin to think about their diabetics that way. Because sometimes a chart reviewer can't find that, right? If they didn't do a monofilament test or they're not examining and you don't see it in their exam, you can't really suggest it. So a lot of this is training the individual providers to make sure we're looking at it, looking for it. But as you guys know, all these things are things that we're looking for. And again, you guys are far enough down the road already, in my view, that it is okay to tell your providers and begin to train them, like putting in 10 different diabetic complications isn't continuing to add to the RAF, okay? But peripheral vascular disease, proliferative retinopathy, and a diabetic ulcer is. So if you guys begin to get your providers understanding that, then you don't, then when you're doing your AWV and you're like, well, they've got neuropathy and retinopathy and autonomic neuropathy and a little bit of gastroparesis, I'm not gonna put all that stuff in there, I'm just gonna put one that day. The reason we do a lot of ADX, we'll do a lot of ADXs on diabetes, which means additional diagnosis within that category, because if you see someone who's doing diabetes with hyperglycemia, well, the next time they may not have hyperglycemia. Now you've lost a complication, so you want to leave neuropathy on there, otherwise you might miss it the next time. So there's little thoughts like that. The other thing is you can have diabetes with hyperglycemia and diabetes with hypoglycemia in the same note, right? A1C is 8, but they're brittle and they have a bunch of sugars in the 50s. That's a very, very big risk adjustment, the hypoglycemia. And as we all know, as we get into taking care of our Medicare age people, you know, living with a hemoglobin A1C of 7.8 and not having them go to the ER with hypoglycemia is a big way to, you know, their life expectancy at that age is no longer long enough that you have to be so tight, right? So anyway, those are things that you guys already do well, but as you're chart reviewing, you'll see that. Next slide. So just again, the complications are important at raising the risk score instead of, like in the old days, we used to put ICD-9 250.00 and it's like, I'll just type in my note everything I'm really doing, but I don't want to put a bunch of codes in there. Or now we're having to think about our documentation differently. Next slide. So this is an example of a 76-year-old male with a GFR 24 about 6 months ago, and it was 22 last month. History of amputation, a femoral artery stent, and has a foot ulcer. So it just begins to show, you know, the foot ulcer is additive. Diabetic angiopathy is another way to say peripheral artery disease. So we'll teach you what are synonyms and all in the same category, and your group can decide what words do we like for our diagnosis. What do we like to read when we're reading each other's notes that makes sense to us? Of course, you've got the amputation, you got CKD4, so you begin to see that risk score come up to 1.976. Next slide.
Do you see from any of your primary care when they're getting the MIT forms, if they're being followed by endocrinology, that they're not doing the reassessment on the diabetes? Because I know we've had some who said, I'm not putting in the diabetes codes because we're seeing endocrinology will let them do that. But
So
now it seems even more important.
yeah, so for everyone on the phone, if you heard that, Melissa asked, are we seeing if the patient's followed by an endocrinologist, do we have any pushback by our primary care folks on not wanting to do all the diabetes stuff with the assumption that the endocrinologist is going to do it? So we train that we need to do it. Now, the good news is, I didn't cover this when I showed you the MIP form. But if that code has been put in this year already by anybody, then you'll have a date in the current year of service. And so if it's already been done and you're not really managing it because an endocrinologist is managing it, then the good news is you won't need to put it in that day unless you want to, unless you're going to do something with it. So it only happens like in January and February, but we do train if it's not in there, because you can just say, you know, followed by endocrinology, and that's all you have to say. So it doesn't take a long time, but we do train to go ahead and put it in, even if they're followed by any specialist. This is just reminding us how we diagnose diabetes. Occasionally we'll have someone who has a patient who's fairly new to them and they actually meet criteria for diabetes and they just haven't called it yet because it's, you know, it's mild diabetes. And so if they meet criteria, of course we want to go ahead and diagnose it. And again, the major complications are additive. So that's what the proliferative retinopathy, end-stage renal disease, CKD 4 and 5, hypoglycemia is additive, and ulcer and peripheral vascular disease. So those are your things where you're like, you know, I want to make sure we leave neuropathy on there because hypoglycemia might not be there the next time. So we'll be able to show you how you do that. And like CHF, diabetes is never considered cured. So, you know, sometimes you'll have someone who meets criteria for diabetes. This is another one where the patients would hate to have this on their problem list. If they get their A1C down to like 6, they're like, why are you? But anyway, it's if you ever had it, you always have it. You're just diet controlled, well controlled is how we would diagnose that or document that. Next slide. So these are some of the pitfalls that we talked about that are the common ones that we came up with. So, you know, the tortuous aorta, code I-77.1, which is stricture of the artery, only applies to actual limited blood flow seen on an angiogram. So when radiologists call this, by the strictest definition, they can't call it. It needs to be an active study where they could actually see it. You can't just take a still picture and diagnose it. So that's the reason we say, unless you're in the cath lab or whatever, you can't really diagnose that one off of a radiology study. Metastatic breast cancer, we want to make sure that we use the secondary neoplasm metastatic site for metastatic disease indicating the cancer is active or history of. So again, we basically were not doing a good job of diagnosing of putting in codes for the metastatic bed. So we want to do that. You know, carotid artery disease translates to a disorder of arteries and arterioles unspecified, I-77.9, which is a high risk adjusting code for rare arterial conditions. A code for carotid stenosis should be used instead, which does not risk adjust. So there is like there literally is carotid artery disease, I-77.9. That's not considered atherosclerosis of the carotid artery or carotid stenosis. That's really some weird problem with the carotid artery. So don't use that specific diagnosis unless they have that. You know, coronary artery disease with stable angina is one that we miss a lot. People are on long-acting nitrates, and we weren't always putting that in. We're a lot better at that now, but you guys will be good at that right off the bat. You know, if people have asthma, our EMRs will tell you there's, maybe there is, I'm not smart enough to remember, but there's like 70 different kinds of asthma apparently. Most people have obstructive asthma, so chronic obstructive asthma risk adjust. The other asthmas don't. So sacroiliitis, you'll see physical therapy notes, or maybe an orthopedist says this, and really they're only talking about the kind of sacroiliitis that is true inflammatory disease, not I'm having some SI pain, joint pain, and they're doing some manipulation and therapy helping me out and it gets well. It's a chronic disease. Otherwise, we shouldn't use sacroiliitis. So we can code sick sinus syndrome or complete heart block with patients with a pacemaker, and that risk adjusts. You know, don't forget about your ostomies and transplant patients, paraplegia. You know, trying to train our docs, our coders will be telling us, again, we'll put in the HPI uncomplicated diabetes mellitus, and then we'll have diabetes mellitus CKD in our assessment plan, and that's, Medicare doesn't like that when you're contradicting yourself if we were to get audited. And then the big one that we talked about, morbid obesity with BMIs greater than 35. Next slide.
That is it.
That's it.
That's it.
We should probably give everyone a bathroom break before Nicole gets her part. You wanna take 5 minutes, everybody, and then we'll have Nicole do her part.
Okay.
Thank you, Dr. Spencer.
You're welcome. Michelle, you can give me my report card later.
Get off mute, Dustin, if I give you A+. Nicole, I think you can pause the recording if you want to.
I didn't go off mute there either. I will pause right now. Thank you, Michelle.
Yeah, okay.
Knows. Is everybody able to see my screen?
Yes.
Yeah.
Okay, and everybody does have these materials as well. Run through a couple of these supplemental files that Dr. Spencer mentioned that we did include. The first one I'm sharing is the HCC condition categories, the hierarchy of those. So this will show which HCC category it's in, RAF score, as well as if it does trump any other categories, what those categories are. So we do have, if metastatic cancer is in HCC category 8, that will trump any cancers or any codes found in HCC categories 9, 10, 11, and 12. So this will be in your inclusion, or all of your attachments here. It does go through all of these. Any questions or concerns on these, or Michelle, anything additional to add?
No.
All right.
If there's any questions.
I think these ones are pretty easy to understand. It's a nice reference point of if I capture something or if I suggest something in this HCC category, does anything else get captured in other categories as well? Next one here is the common HCC codes. Some of our other PMRR, I guess, expert reviewers have found that I think it's 85%, 90% typically of all suggested codes or used HCC codes fall into this 2-page cheat sheet really here of the most commonly used codes. So it does break it down, diabetes, and breaks down by different body categories, kidney, digestive, endocrine, and so on. This one is a great one to have printed off. I know the Wilmington reviewers, I think really printed all of this off, to be completely honest, and made it into binders. So they each have a PMRR binder with all of these kind of reference points to go back to. But this is a great one. I think they had these laminated actually. not only for the reviewers, but for the primary care providers as well. All right. The next one is guidelines for indicating significant and chronic diseases from Agilon. And this just walks through, this is the most recent version, excuse me. But it does walk through a lot of what Dr. Spencer just walked us through for the chronic diseases part. So when suggesting aortic atherosclerosis, here are the different requirements that are needed. And walks through a lot of the common diseases here. I won't go through all of this. This is for everybody to look through. Again, can be helpful to have printed out or at least have the PDF version in an easy to access area. Another thing that we actually started in the Wilmington market, which I mentioned on Thursday to a few of you, that I think could be a great idea for the Pinehurst market as well, is in addition to this document, we created a PMRR archive. So from these, some of them are questions that are completely separate from any of the diseases in here. Some of them are in addition to. I know we had quite a few discussions at the beginning of Wilmington's PMRR program around aortic atherosclerosis. And, you know, I think I understand exactly what this means, but they would reword the questions and we'd have a PMRR expert answer them. And we kept all of that material is in an archive for all of the reviewers. So it's kind of a supplemental file like this. I know we talked a little bit earlier, Dr. Spencer talked about senile purpura. That was a very big discussion in Wilmington as well. And I think I have probably 6 or 7 slides on different questions and answers and details in Wilmington relating just to senile purpura that I'm more than happy to share as well. So I think that might be a great idea for Pinehurst. We'll create an archive of all of our questions and answers to go along. And the next one is just a provider burden of illness quick guide. Just through a lot of this other information that Dr. Spencer walked us through, chronic conditions, as well as kind of what the overflow of the process is. Again, I won't walk through all of this. Any questions on any of this stuff right now?
No.
Perfect, even easier. The last thing we had is the supplemental training for getting into core, which Michelle is going to help us walk through since she's a lot more experienced at getting everybody into core than I am.
Okay, so Nicole, I'm gonna grab the screen share.
Yes, please, thank you.
So everyone will receive, if you haven't already, credentials to log into what we call our core platform. Before you get.
Sorry, Michelle, just wanted to say, I did send out an email last night for everybody that says what the username is as well as your temporary password. So if you have not actually tried to get in, you should have that information in an email from me, probably about 9 o'clock last night or so, but it did go out. Thank you.
Does that also include Horizon?
The Horizon went out about Tuesday, I believe. I sent all of the Horizon information out that included the instructions, a quick video, usernames and passwords. And then I didn't hear back from every reviewer about if they had a chance to get into Horizon. So I thought I would send the core passwords just in case. So that email did also include a attachment on kind of some quick information on how to get into core.
Thanks. Horizon is our virtual desktop software for security reasons. And so if you have trouble with that, what I've learned from our help desk working with some of the other markets is Google Chrome is the best browser to use for that. So if you have Google Chrome, please try to use that. So you would log into Horizon as your VM software. And then within Horizon, there's going to be a link that says Axis Launcher, AXIS Launcher, that takes you to this core screen. So when you first see the core screen, it's going to ask for your ID and password. So it will. It will look like this. It'll say MDX Access Log On. And so your session, the first time you log in, you're going to have to choose your session through this drop-down box. And there's a session for North Carolina. So you'll choose that. You'll put in your username that Nicole sent over, which is typically your first initial and last name, and then that temporary password. When you enter that temporary password and click OK, the first time it's going to tell you that your account has been flagged for a password reset. So at that point, you can choose your own password. Just remember it. However, if you forget it, we have a link here, forgot password. If you click on that, you'll get this screen where you'll just enter in your email on file, which is your Pinehurst email, and click OK, and you'll get an email with a temporary password. The first time you log in, it's going to take a few minutes for the system to config, but after that, you're going to be able to log in really quickly. So just have a little patience the first time while it's configuring. Once you get logged on, you're going to see a screen that looks similar to this. This is our landing page. Well, let me get to the landing page, sorry. The main screen, it'll say Agilon Core, and you'll have application screens. You won't have all of these selections. You'll only have a selection that says member management. You'll have code lookup, and you'll have physician review. So physician review is going to be the application that we're working out of. Before we get to that, I do want to show you the code lookup tool. I don't know how good your EMR is with looking up diagnosis codes or flagging HCCs, but we do have a tool here where if you click on code lookup, it will pop up in a different window. And here, if you select a specific HCC, just for example, let's do other significant endocrine and metabolic disorders, HCC 23. You select that, hit search, and it's going to pull up every ICD-10 code that's in that HCC category. So if you're searching for a more specific code, then you can look at the code list for the entire HCC. Or if you know a partial ICD-10 code and you want to see if there's anything that's more specific, you can put in a partial code. So if I type in J44 and hit enter, it's going to pull up all of the codes that begin with J44, and then it's going to tell you whether it's an HCC code. So anything that's blank here, it's a valid ICD-10 code, but it's not an HCC code. You can also put in partial descriptions, but a lot of times this pulls up so many, a list so large that it's not as helpful. But if you put in, chronic obstructive, then it's going to pull in all of the diagnoses that have chronic OBSTR in it. And you'll see this one that pulled up that is not an HCC. That's just a little tool that we have available to you.
And a note there too is, I know Melissa and Dr. Daly, we kind of chatted on Thursday about the code lookup and the difference between this core application that reviewers will have access to and use, and the core portal, which is a much more limited version that's meant for practice managers or nursing staff to help with generating MIPS. This code lookup tool is also available on the portal as well, though. So you could even ask your nursing staff or whoever has access to help with that. So just a reminder that that tool, it's absolutely fabulous. I use it numerous times a day, and that it will be available on portal.
Okay, thank you.
Okay. Now to the meat of it. So once you get logged onto the screen, we have a physician review work queue that is set up, and it's based on the appointments that are scheduled. So we have identified appointments that we have mapped to AWV, which is annual wellness visit, a CPE, which is the complete physical exam that some of the payers will pay for. And we have also mapped your HRAs so that they trigger a physician review or a provider review. So when you get logged in, you'll just click on this physician review tab. And it takes just a moment, and you'll get this first box that asks you which region. So you'll drop down and you're going to select Pinehurst, because we also have Wilmington in this same instance of core. So select region and click OK. And then this is going to be what we call a prebble, or it's a location. You can just select all, because right now we have all of your locations just in one pod, but just select all and click OK. At that time, 3 other screens are going to pop up. And if you're using multiple monitors, they're probably going to pop up on different monitors. So I'm going to give it a minute to pop up, and then I'll pull it over to this screen that I'm sharing so you can see all of the screens that you'll receive. Okay, the first thing you're going to get, and what I would encourage is when you first start doing the chart reviews, get these screens lined up. And you may have to shrink them down. Like you'll see, I think when this one first pops up, it's more like this. So the MIP shows over here in a small format, and then here in its actual format. So you want to just move things around, close that, maybe make it a little smaller so you can get more on your screen. You also want to zoom so you can actually read what's on there. So you'll get the MIP, and how they're triggered is based on the most recent upcoming or soonest upcoming appointment that is an AWV, a CPE, or an HRA. So you'll see the patient information. You'll see if we have a record of their last annual wellness visit that's based on your historical claims that we've received from you, the next scheduled visit and who it's with, and then who their PCP is, and this is based on the information that we got from you right now. So it'll have the PCP, and it will have all of their known chronic conditions. So these are the conditions that were found in your historical claims in a look back period over the last 2 years. And so these will be HCCs, except for the few that Dr. Spencer mentioned that compliance requires us to put on the MIP for hypertension and hyperlipidemia, or one of the hypercholesterolemia codes. Here it will tell you who coded this the last time and what their specialty is. It will also tell you that all of these were found in historical claims in 2020. And then these 2 were also found in 2019. If the condition has already been assessed this year, meaning that we received a claim for it, because we'll be getting daily claims files from your system. If the current year date of service has a date in there, that means that it's been assessed for the year, it's captured in claims, it's received or been sent to the health plan. And so the rendering provider won't have to do anything with those. The important part about this section for our reviewers is that these are known conditions, so you don't have to suggest these conditions during your PMRR process. The other window that pops up is this case management screen, which it stays behind no matter where you pull it, it kind of stays behind. And so it will show the patient information here at the top, and it's going to default to this DX change and audit screen. And this is where you're going to see your suggestions. If you ever pull up a record and you see information in there, that means someone else has started a review on it. And so they may have not completed the review. or they completed it and forgot to click on complete and exit. But we'll talk a little bit more about that. The most important screen that you will get is this screen here, which is your data entry screen. So it's pre-populated with a few items, with one being the provider that's seeing the patient. So this provider will match this next scheduled provider. And the date of service is going to match this next scheduled visit date of service. So you'll pull up this patient's record. You'll see we already know about their lung cancer and their dependence on hypnotic or some other medication. If you'll remember, Dr. Spencer, we talked about this just in the training about, you know, if they are on medication and they're using it appropriately, then it may not be a dependent situation. And so this may be a code that you want to recommend the provider looking into to see if they want to continue with that code. But you would open up your medical record, review all of the notes, and you will go over in some of the meetings that are going to be set up, just that zoned approach that helps you go through the medical record in an efficient way, but identify those conditions that the patient may have that's not on this known list. And if you find a condition, an ICD-10 code, then you'll go back into this screen, and here you're going to enter the diagnosis code. And I'm actually going to switch over to our test system because this is production and I don't want to enter anything into the production system. So I'm going to move this over and bring over a test patient.
Michelle, if you did want to enter it, I could delete it.
Oh, I forgot. You have special
Yep.
powers.
Yes, so if you enter anything, I will delete it for you right away.
Okay, yeah, no, let's do that because that way they can see how the MIP's updated as well.
Yeah.
Thanks for reminding me on that. Okay.
Not a problem.
They give Nicole a lot more control over core than they do me. I don't think they trust me deleting things.
It's something to keep in mind too. And it's happened probably more often than the Wilmington reviewers would like me to mention, but it happens. You put something in, maybe you put it in wrong, or you put something in and you realize afterwards, oh, I did not mean to enter that code, or I didn't mean to say EDU, it's supposed to be something else. If you just let me know, I can always delete any of the entries that are not accurate as well.
Okay, so I'm just going to write this patient's name down so you can pull it up and delete. All right, so say you're reviewing the record and you see that the patient is morbidly obese and you want to make that suggestion. And so here in the diagnosis code, if you know the ICD-10 code, you can just type it in. If you don't know the ICD-10 code, if you click on this little ellipsis here, it's going to pull up this diagnosis code select screen that we just looked at for the code lookup tool. And you can search for the diagnosis code and select it, and it populates into this field. Then you're going to choose the source. So this is what tells this entry to show up on the member information profile that the rendering provider is going to get. So you're going to select physician reviewer, and then you're going to put in a memo that tells the rendering provider why you're making this suggestion. And so, you know, you can put in BMI is greater than 40. If that is the only entry that you have to make, you would just hit OK. But we're going to pretend like there's more to enter. So here we're going to click add. And you'll see behind here, it just added that entry that I made for E6601. And this goes back to diagnosis. And the source stays there, so you don't have to continue to select that drop down every time you enter something for the same patient. So here, now we're going to see this patient has F13.20, and we're going to make a recommendation for the provider, or we'll put an education remark, since this is one that we do a lot of education on. So we'll put EDU, which means hi, PCP. We see something on this record that we just want to make you aware of, and it's totally up to them of whether to do this. And so we could put the memo as substance dependence. Coding requires DSM-5 criteria to be met. Please ensure this code is appropriate. Okay, so we're going to put that in, and then we're going to click add, and you're going to get this pop-up that says, hey, EDU is not a valid diagnosis code. Do you still want to use it? And we just say yes. And then you'll see that pop up over here. Okay, so then, we are moving along, and we see recommendation that we want to make, put in REC, and we'll make, recommendation for follow-up with pulmonology or something. Probably not, since they have lung cancer, but okay, so say making that recommendation, and now we have all of our entries in there. So we're going to click OK. Yes, we still want to include this, even though it's not a valid ICD-10 code. That window goes away. You see all of your recommendations. The MIP hasn't updated because this is a static view of the MIP when it first pulls up. But if you want to see what it looks like after you make your recommendations, if you go over here to open or refresh member info, this MIP is going to be refreshed. And what I hear a lot of our reviewers say is that, especially when they're learning the process, they want to make sure, they just want to look at it and make sure that everything they entered shows up on the MIP. So this part was added where now it's action requested, please assess the indicated conditions and or notes. And so this is where we're going to ask you and the other primary care providers to evaluate these conditions. And so if they agree this patient is morbidly obese, then they will say, yes, I agree with it, document it and put it on the claim. Anything that's EDU or REC, they can, come back and say, no, I don't agree with it, or yes, I agree with it. And then we can close these out in core so they don't continually pop up on the MIP. Or if the provider disagrees, if this patient, they lost weight, so they're no longer in that obesity category, they can disagree with this. They'll return the MIP back to Nicole or the coder, and they will suppress these so it doesn't show up. So any questions about that process so far? Good. Okay. So then once you enter all of your information for this patient, you can close out the member information profile. And then at the bottom, if you are done for the day, you don't want to review any more patients, you hit complete exit, and it's going to take you out of the screen altogether. If you hit complete get next, it's going to give you another patient, and everything will pop up, the MIP, the DXchange, and case management. Now, one thing that we ask, if you happen to get one of your patients, because again, these are just triggered based on whoever has the soonest upcoming appointment. And so if you get one of your patients, we have to ask you to skip that record, because for compliance reasons, we can't pay you to review your own patient. So if this patient, is being seen, and if Angie was the reviewer doing the review, then we would ask that you go down here and you skip the chart. And skip chart's not working, Nicole. We're going to have to put in a ticket for that.
Okay, I jotted that down.
Yeah, so the skip chart should be lit up, and you would select skip chart, And then it would ask you why you're skipping it. And there's a selection for I am the PCP. If you pull up a chart, you see that they have all of their chronic conditions that are already known. They're already on here. And you review the chart and you don't see any information to add, then you're going to put in the diagnosis code, just NONE for none, and then click OK. And that will identify that the chart was reviewed, nothing was found. So it doesn't trigger again for someone else to continue to look at it again. So once you get everything completed, it'll just take you back to this screen. Now, if you leave Core idle for 15 minutes or more, it's going to log you out. And so if you were in the middle of a chart review and you get a phone call, step away, come back and you're logged out, or it's locked, you'll get a lock screen and you'll have to put in your password. When you come back and you want to go back to that chart that you were reviewing to complete it, you're going to go into this. Yours will say member management, but it'll look the same once you open it. So this will pull up a screen where you can search for the patient. And what you can do is you can enter their last name. If you hit enter, it'll pull up everyone with that last name. You can also enter the date of birth. That will limit those. So this is the patient that we were just reviewing. If I click once, this is going to pop up in this summary screen. So the default screen is the summary tab. That's going to have information about all the diagnoses that have been on claims that we've loaded into the system. To get back to that entry screen, you're going to click DX change and then audit. And I have screenshots of all of this, and Nicole and I will walk through this with you more until you get the hang of it. But here's all of the information that you've added. And if you have something else to add, you'll just click add. And you'll see that same screen. The difference is it won't have the provider name. So you'll have to enter the provider that's seeing the patient. And here you can put in the partial last name. And if you hit tab, if that's the only match, it just populates with that provider. If there's more than one match, it'll give you a pop-up screen and you just select that provider. The date of service will be defaulted to today. So you'll need to change this to the 15th since that's their appointment date. And then everything else is the same. Entering the diagnosis, selecting the source, the memo, and then add or OK.
So are you saying that once we're in the chart and we get interrupted, there's no way to go but save it and go back without putting all this extra other stuff in?
Yeah, if you click incomplete save, or well, if you don't click complete save or complete get next, it will save the entries that you made, but it won't consider it completed as a chart review. So it goes back into this review. So
yeah, put all the other stuff you just put in there. Is that right?
Well, all of the stuff that you put in there will still be there, but if anyone else is also reviewing charts and they click on this physician review, that same patient may pop up for them as well.
But to access that patient, I have to put in the provider, the date, and all that other stuff, correct?
To access the patient.
Yeah, sorry, to access the patient, you would need to look them up under the member management. You could just use their last name. To be totally honest, that's usually all that I use. Even if I put in Smith, I'm going to see a bunch, but I can pretty quickly find which patient. This is a lesson that the Wilmington reviewers actually kind of learned the hard way, is they weren't necessarily jotting down like a last name or MRN or something to know which patient they were working on. So there were quite a few times at the beginning, and actually still now, where I'll get a frantic message of, I was reviewing a chart, I got pulled away. I have no idea who the patient was, so I don't know how to go in and finish. We can help find those, which patient you were working on, and get you that patient back, or get you the name at least. But that's a good time to just point out that if you have a chance to jot down the patient's last name, MRN, something so you know who they are, initials, you know, some way where we're not writing down PHI, but at least so you know who you were working on.
So I'll,
And I'm not gonna do that again. I'm just gonna finish. When the providers get the missed form, they could just fill out the piece of paper and hand it in, or are they gonna access this portal too and input things like yes, no, or things like that? Which one are they going to do?
Paper.
Paper?
That's
And
a
then,
great question.
and then who's gonna change the codes on an EMR after the paper's submitted?
so
The provider.
The provider is still supposed to document it and put it in the chart.
Right, at the visit.
Except agreeing or disagreeing on the MIP form is what helps that agreement rate that we were talking about yesterday,
Right.
and the capture rate.
So the MIP form is really to Agilon to update their claims records for their database. But the provider has to take a piece of paper and go into the computer and change the EMR record, correct?
Right.
Okay.
Which is similar to what we did on the HRAs. We had the, the form from the hospital. They expected us to enter a new code if it was appropriate.
And as
Which is why the concept that still needs to be had is helpful, because it's so much easier to get a task and then have the charts linked.
Yeah.
Go in, they get a piece of paper, type in the person's name, and you know what I mean? But if they're getting the form at the same time as their visit, it hopefully will work.
Right. Yeah. But ideally, once we're up and running, we have this thing down, it'll be an electronic. When we put the code in, the provider can see it on an alternate screen and just click on it and it'll go in there, but we're not there yet.
Right.
yeah, that is something we discussed a couple times already, and something that Wilmington Health actually just incorporated into their system is they no longer use these generated MIP forms. Reviewers still enter everything exactly the same way. Everything still works the same way, except this MIP information, including historically known conditions that need to be reassessed, along with PMRR suggested conditions, that is automatically generated into Wilmington Health's EMR. So providers can click on it in there and say, yes, I agree, and then add their documentation. The suggestion was for obesity, and they said yes, and then they make their documentation that the BMI is over 35 and this is the comorbidity, and drop it right into their note. At the same time that they're able to do that, it would send the file back over to our core database here, letting us know that it was completed as well. So it's kind of two birds, one stone. And that is definitely something to work towards down the line.
And Nicole or Michelle, there was a question earlier is there a test environment for this if they want to do a couple of test reviews after the training to get the feel of it before they're in the live environment? Is that possible?
We do have a test environment. I'll have to ask if their user IDs are attached to it.
There is one of the questions that I have for all of the reviewers is times or dates or days of the week, and times that work best for everybody, so we can start scheduling our PMRR meetings, which initially they'll be once a week, hopefully 45 minutes to an hour, and then over time they will kind of be less frequent. But one of the things, I guess the plan for our first meeting is we want everybody to have some time to get in, even if it's in the live environment, and just play around as Michelle mentioned, all these things that she's walking through, we do have a 15-page document that was included in all the documents I sent out yesterday. So you can walk through it. We want everybody to have some time to play around with it. If you make any mistakes or do anything that you don't really realize, as we mentioned, I can delete them so that we don't have to worry too much. It can be cleaned up. But after you have some time to really listen to this, kind of soak it all in, play around a little bit, we will have Dr. Doherty from the Wilmington Health Market come on and really walk through it then with you again. So live at a meeting, probably virtually, but he would be able to show you, walking through core as well as how the 7-zoned approach and all that good stuff. So we will double check on the test environment. Your logins definitely do work for the live environment though.
Hey, Nicole, as we're starting the process, if the reviewers have questions that are after hours, like after clinic hours or on the weekend, is there going to be a best way to contact somebody for troubleshooting?
Of course, I'm always here. I guess the midnight 1 o'clock in the morning calls, I can say I probably will not answer if there's any of those. Other than that, I'm here. Michelle's also available usually, and I will send out an email that has the email address for our core support team. If you have a non-urgent question to email, I am also happy to submit those tickets at any time. And then there is also a phone number to call. If there's definitely like, hey, I can't get in or something is really going on and I need to get this fixed so I can do some reviews. You have extended office hours now, so they are available on evenings and weekends.
Thank you.
Mm-hmm.
I did get the skip chart to work. I think I clicked on something else before, but if you get a patient that's yours, if you hit skip chart, it pulls up this, and there's different reasons. And we need to add I am the PCP reason, but there is a reason for that. And hit OK, and that goes out of the work queue. And pulls up the next patient. So any other questions about this? And once you get done, it's just, you can either click this X to close and it logs you out, or there's a file exit. And I'll just take you out, log you off.
Is there a queue for each reviewer, or is it just one big queue for the Pinehurst Medical Clinic? And when you click on, you could do them all if you were energetic, or or if you're on vacation, you wouldn't do any, and everybody else would do them. Is that how it works? You just
Yeah, it's one big queue. So, we'll have reviewers working at different times. And so it just queues up the patient that has the soonest upcoming appointment. And if you notice, like these that we're getting right now, they're for appointments coming up on Monday. And since we're not going to technically go live until April 1st with the AWVs, then Nicole and I will go in and skip those. So once you start reviewing them, it'll be for visits that are starting April 1st or after.
do we have a queue yet for beginning for April 1st, April 7th?
Yeah, it's out there, Nicole. They're out there. Everybody's out there. Nicole and I'll just have to skip through these that are for the next couple of weeks and get you to the April 1st.
Queue is live and running. Michelle is in the actual legitimate queue that we have. So it is fully live and running. Michelle, I don't know if you know, is there anything horrible if a provider did go in and make suggestions if they wanted to practice on patients that have appointments prior to 4/1?
No, I mean, that's fine. You'll just, I mean, if they're real suggestions, valid suggestions, we'll just leave them in there. Because even though that patient's coming in for an AWV, if they come in for another type of visit, and we make the decision, and this is something that all of y'all will have to discuss and determine if you want to print MIPS for all of your PCP visits or just AWVs, but the MIPS can be printed for any visit. So if the patient is coming, back in and there were new suggestions made, or we got new claims showing that there's new known conditions, then that information will show up on MIPS. So it doesn't hurt. I mean, yeah, if you want to enter suggestions.
In regards to this queue, are we only going to do Pinehurst Medical Clinic patients, or will we get Wilmington patients as well?
No.
I'd say this morning, actually, I think Wilmington was so used to just really being the only market in this North Carolina instance that the reviewers were going in and clicking this physician review. And when it popped up, they just clicked OK. They never even paid attention to the fact that it said all. So I got some frantic emails this morning of, I just got a patient that lives in Southern Pines. What do I do? What's going on? Is something? Yeah. And I was like, oh, yes. No. And I sent out actually part of the screenshots that is in the supplemental training for core that we sent yesterday saying, all right, now that you guys have more than one market, you have to use this drop down and pick for them Wilmington, but for us Pinehurst here. Otherwise, yes, if you pick all, you will get Wilmington patients if they have the next soonest appointment.
That does allow us to, that does allow us to cross cover for one another as we get better. Like if everyone's gone on spring break or something, and you're like, hey, can you guys get in there and knock a few out, catch us up? Then we'll do Nicole will be able to help manage that over time. But ideally, at the beginning, you want to learn on your own patient.
Is there a way in the settings or preferences to choose that to default based on the user?
Not that I know of. Michelle, do you know? I don't know if we even asked that.
But I'll ask.
That's a very good idea. So I think Wilmington would prefer that as well, honestly. And kind of going off what Dr. Spencer said, one thing that we've started doing in the last 4 or 5 months is we've found doing some cross-market case studies. So in PMRR meetings, at first we'll do a lot of question and answer, kind of going over some different areas. But then as we get more familiar with everything, we kind of switch to doing case studies. So it's one case study that every reviewer goes over and enters in their suggestions, and they send it all to me, and we'll get it together for a presentation to show, like, okay, why did Dr. Daly suggest, morbid obesity, but Dr. Antil didn't? And we'll be able to look at that and kind of compare. So it's great to not only do that within our market, but also to do it with other markets. So we've done a few in Wilmington now, I think 4, that originated out of different markets. So we can do, Wilmington will be a little more, have a little more experience with these PMRR reviews. Somebody like Dr. Spencer's market's going to have a lot more of experience, and some of the Ohio markets. So it's very interesting to see kind of cross markets. So I think this, having these different instances in core could be very, very neat so we can see how everybody else is doing.
In our queue is being named Pinehurst, and we have a large, primary care section in Sanford town. Should that say Pinehurst Medical Clinic? Right up there, or do you think that'll be a snag or a slight to the people in Sanford?
Or once we have our actual name, call it Evergreen.
Yeah, I call it.
More.
I mean, you think that matters for Melissa? That did we just leave it Pinehurst there?
I mean, as long as they know. I mean,
although people know they're not being left out, but
well, I think the only people that will really see this would be reviewers.
Okay.
In this specific area. And Dr. Charity, I saw you had a question.
I think you're on mute.
So if we wanted to, we can log
I-
on and pick someone that's due before April 1st and do some things if we wanted to, then email Nicole and say, please delete all this stuff, right?
Yeah.
Okay.
I am trying to figure out how to unmute Dr. Pasharity. I can ask to unmute, but that's it.
Nicole,
You
I think
see-
he had two, dial in and,
Okay.
on the web. He was on there twice, so you may have unmuted the wrong one.
Dr. Bashadi, what do you think about the time?
Well, he might be trying to say something about that.
They might be thinking-
Yeah. If you want, Dr. Pasharity, you could also send a chat over and we can read that too, if that would help. I'm sorry, I don't know why we can't get that off.
Can he unmute his own from his screen at the bottom left?
He's just asking, has anyone been able to log on?
Yeah, he got it.
So we have another question about that too. Julian, Stacy, it says failed to connect to server.
Mine said that too.
When you selected the session, did you select North Carolina? Because the first
Yes.
selection is, okay. That's usually what that means.
I think, I don't know if it would be helpful to have a core support person kind of walk through it. I know I get that error at times, kind of random times. And sometimes it's, I don't know if it's a timeout of my internet or what, but I honestly, the best way that I found to fix it and quickly is I close my internet completely. I disconnect from internet. If I have a wired internet, I unplug it or I disconnect from Wi-Fi and then try to log back in, or connect back to internet and log back in, and it works. I'm not saying that's the best way to do it. It's just I get very frustrated and I want an answer now, and that works for me. So it works. But I will.
Stacy
Actually-
tried that and that didn't work.
Okay.
They have the Horizon thing on with the security, is that why, I mean, is there any issue with the Horizon?
Oh, yeah, you're right.
Yeah.
You can use that in this building. You gotta go home to use
So
the,
the first time I tried setting this all up, though, was at home. And
Now, you can
you were.
you can use Horizon here, Mike. But
You can use it in there?
yeah, but we also, I use Horizon in here also. Is there something special that I have to download a different version of Horizon, or because I already have Horizon on my computer, there's a problem? Is that it?
Well, I know Stacy mentioned early this week that she had some issues. So I actually reached out to support to see if they could help. And the message exactly that I got back is the error message that states cannot connect to server usually means that the session information within Access Launcher is not set up properly, or is there an actual connection issue to the server that desktop services can help remedy.
I work with Dale, Brett, our IT person. She said the VMware we had was fine. It didn't have to be downloaded and uploaded and changed. She said it was fine the way it was.
Okay.
Well, if anything, I will be the first to admit that I am not an IT person. If I wasn't married to an IT person, I don't think I'd be doing anything on a computer at all because it just frustrates me. So as much as I can't help, I can certainly help facilitate conversations with the people that can. I think Michelle knows I will be that person to be the squeaky wheel until we get an answer that we need. So I can reach out. I think if anything, if we can set up a time either with our support team, and if it would be best to work with your support team so that they could support you on site, we could certainly work that way, or whatever you guys think is best.
I'll have the portal, but not the physician, the renewal.
In other new markets, what we've done is we've set up like office hours, because I know each of you probably have different clinic schedules. And we've just had one of our IT support people log on. We set up a Zoom meeting. They log on for 30 minutes. And if you're having problems, you can call in anytime during that 30 minutes. And if you can share your screen, they can actually take control and do things that, that they may need to do to get it to set up correctly.
I think that's a great
Yeah,
idea
that
if you
would be
guys
great.
do. Okay, Melissa, can I just work with you on helping to get some, a time set up and we'll just get that working?
Sure.
Awesome.
That is pretty nice. I've had to do that before where you just give them control of your screen. They just run around and fix everything.
That's my favorite way. They get that D number, whatever they call it, they can just take off.
Yeah.
All right.
And then while I have everybody too, for the reviewers that are with us right now, I know there's at least one that was not able to make it. Is there a day of the week or time of the day that works for most everybody to start setting up PMRR meetings? I think that is a very important next step, is to make sure that we're getting you this initial information, but then also start reviewing it in meetings. And it can be hard to get everybody's schedules to cooperate. I know some markets do, like 1 week they will meet on a Wednesday at 5, and the next week they'll meet Thursday at 6:30. So we can certainly do stuff like that, but at least to try to get some initial times. Wilmington, I think, is every Tuesday at 5. Now we're once a month, first Tuesday of the month at 5, but we started it every Tuesday.
And then obviously prefer non-office hours, and I certainly prefer evenings.
So you kind of saying most days at 5 o'clock
About 5 o'clock, I think, is the working on it.
or 5:30? 5:30?
Yeah,
Could
I
need to
agree.
be At least 5:30 or later,
Yeah.
because we're still seeing patients. Our walk-in clinic is kind of variable. It would be
Yes.
hard to make a 5 o'clock.
I would say 5:30 or 6 for me. Any day during the week is fine.
I guess
Yeah.
not Tuesday, because we will have one Tuesday a month that will overlap with Wilmington's then. Is there a day of the week that anybody would prefer?
Definitely not Monday.
I agree.
Maybe
Yeah,
not Friday.
I was gonna say Friday. Does anybody want Friday at like 8 p.m.? No? Okay.
Wednesdays are a good middle of the week day.
I
You
like
will be
that.
the only one to attend.
Would it just be me? I show up every Friday waiting for everybody to show up and nobody joins me?
How
Or
about
for the
Thursday?
weekend?
How about you
Do
guys?
Wednesday, Thursday, doesn't matter.
Let's start with Thursday at 5:30. And then we can adjust if that doesn't work. That's just,
Yeah.
get us started.
Oh, definitely. I already have my email group set up, so I have, you get some emails from me. But definitely don't hesitate to let me know, and we can adjust when and where needed. And then
How
I
much
guess
time should we block off for the meeting?
I will send out meeting invites to everybody, so that way, the recurring meetings, so that way everybody will have that automatically blocked off on their calendars. I think Wilmington, we did an hour. Michelle, is that pretty typical?
Yeah, we start with an hour because there's usually a lot of questions and a lot of great discussion. If we end early, then
Yeah.
that's great, but most of the time we use the same hour. And as Nicole said, we'll back off and do fewer times or maybe
Yeah, I think Wilmington, we started obviously weekly. And then about 6 months later, and we started just about this time a year ago. 6 months later, we went to every other week. And that actually came because we're like, we really don't have all that much to discuss. Everybody was doing so great. And then the first of this year, so about 9 months, 8 months later, we went to once a month. And now the only problem with that is that I really just miss talking to them as much, but they're doing great. So it's not needed. And then is everybody okay with this coming Thursday? So Thursday, the 18th? Or do we want to wait another week? The sooner we can get to just really get it, into everybody that, this is how we're doing it, and the more repetition, the better, but I just want to make sure.
I would say this coming Thursday would be better than waiting.
I agree.
That's just,
So we have two Thursdays in a row, as far as retreat meetings. Might want
Yeah,
to
this
do like
coming-
Wednesday for the next 2 weeks and then.
Coming-
back to Thursday.
The March 25th is our
And the 18th. Mhm.
I always switch it to Wednesday because we have.
I like Wednesday better anyway, but
I did too.
Might make it Wednesday.
We go Wednesday, 3/17,
Sure.
and then the following Wednesdays, and as we said, we'll change that and shift it if and whenever needed. And it's certainly not, if you can't make some of them, we're not gonna send out a mean email or anything. It's understandable, things come up. I think around the holidays, I had maybe like 2 reviewers in Wilmington join me. So it's understandable, it happens.
And Nicole, I'll send you a follow-up email, but we'll need to get Dr. Antil set up also,
Okay,
please.
I think
so in
I
the
have it.
meantime, if we're in
Can you-
difficulty getting on, should we contact you? I mean, are you the right person to contact?
you are definitely more than welcome to contact me. I can really help walk through the different information that's really already in there. I will find the number. Michelle,
If
do you-
there was a direct IT number, that would be
yes.
easier than you having to be, because if you're not the person, then I'm just wasting your time by contacting you,
Sometimes I can, not often. I'm not even gonna pretend. Let me see. I don't know, Michelle, if you have it offhand, otherwise I'm gonna search quick.
Yeah, I'm looking for it because I just sent it.
I usually,
Yesterday. Okay, the help
855?
desk- the help desk number is 855-578-8058.
Okay, got it.
I'll put it in the chat, so.
Thank you.
Thank you.
Yeah, that's usually the most that I do is I can walk through some basics. And then I just contact the help desk for everybody. So, and I am more than happy to do so. But yeah, if you want to call, they do have night and weekend hours. They do actually have quite a few of their support reps that are in the Eastern time zone. So it's very helpful.
Okay.
Some of them are in Hawaii, so
Yeah.
if you are working at midnight.
Yeah.
Someone had asked about, do you need to install a program on your computer?
Yeah, that was me.
Okay, so Okta is an account that you need for multi-factor authentication. But it's also on your phone, so you can set it up on your phone. And there's instructions. Nicole, did you send them the Horizon login information?
I believe that was in the Horizon
Yeah.
emails. If not, if you didn't see this, or if I didn't attach it, just let me know and I will get that out too.
We don't have authority to install any program on our computer. It has to be done by the IES paper.
Oh, your IT, an administrator has to install it.
But I
Well,
think we can just use the HTTP option, right? There's 2 options, install it on your computer or
Yep.
use just the URL option.
Yes, yeah, you're right. So once you get into Horizon, so Horizon is just a web page. And again, Chrome is the preferred web browser to use. And so once you get into Horizon, you do have the option of installing it onto your desktop. But if you are unable to do that, then you can just click on the HTML access. And it takes you to, you have to put in your Okta username and password. So this is the
The one Nicole sent you yesterday, last night.
Yeah, no, the first one.
Right.
The one from last night is the core ID. The one from a couple of days ago, which is your name at Agilon Health,
Yep.
whatever. That's the first one that was sent. And that's the one that you use here, correct?
Yes.
Correct. Yeah, you're definitely way better at this than I am. So I will just be quiet and let you do it. You know your IT better.
I don't know about it. I mean, I got all the way through the process of even the verification and, doing my phone number and being sent a code and then picking a security question and sent a code, got down to complete, and then it pops up, we're sorry. And then it said attempt it. I attempted it a couple of times. That was this morning, so I kind of ran out of time and started this meeting, but I was almost done. And I think maybe what I need to do is go back and do it with Google Chrome possibly as my browser, and take your advice, Nicole, and turn everything off, turn it back on. I mean, try a couple of those things before I call IT. I think that it's when we finally get into core, that's when we use the one you sent us last night, correct?
Correct, which is your first initial last name, and then everybody's temporary password was password 1 with a capital P. And
Okay.
that's where you use that. Make sure you change your password then, so everybody doesn't have the same.
Yes.
But
Of course you do.
good. I am one of those that'll just leave it if it lets me, because I don't ever remember anything.
You're not alone,
Yeah, oh, it's horrible.
but there are medicines for that.
Yeah, so once you get into Horizon, it'll, just like a desktop. And the Access Launcher is how you get to core.
Mm-hmm.
And Teams is something that just gets automatically installed, but I don't think it's operational within this. But I always get questions like, can I use that?
I wish
Teams?
it was.
I know. But yeah, you click on Access Launcher and then it pops up with, get over to this. This screen, make it bigger.
It pops up with, you can't connect to the server. That's where that happens,
That's
right?
where, is that where that happens?
That's where that happens. It says you can't connect to
Oh.
the server, right? When you try that part. But we'll see.
That's where
Yeah, that-
on the NDA is where it says you can't get onto the server.
Guys, it sounds like we need to get one of our IT people on and do a Zoom call with everyone and just get everyone
Yeah.
signed in the first time.
Yeah,
Okay, let's set that up.
yeah. We'll set up, in case everybody can't meet at the same time, we'll set up a couple of different options.
Okay, that'd be great.
And then that way you can just join. So Nicole will send out a Zoom meeting for each of the options and you can just accept whichever one is best for you, but we'll work with IT to get those set up. First, as
Sounds
early as
good.
we can next week.
Yeah, I'll send the email out or to request it from IT today.
And let them know, Nicole, that they
Monday,
need
Tuesday?
someone, let them know that they need to provide someone that can help with both Horizon and Core log on.
All
Sometimes
right.
that's two different people.
Yes.
Has everyone just tried on their work computer? Has anyone tried on their home computer? I'll try on my home computer. And that's just the security on it.
This is where I start like cursing all the bad guys and they just have to put all the security on. We're gonna lock ourselves out of everything.
The hackers can get in, but the people are supposed to.
Yeah, exactly.
That's exactly right too. It's always fun when a hacker could get into my account, but I can't even remember how to get into anything.
But you're saying you get all the way here and then you click on Access Launcher and it tells you failed to connect.
No.
It just says can't connect to server, something like, that's the message.
Okay.
I'll try it again, just based on some of the suggestions Nicole made and switching my browser, and that may be all it takes. I mean, but I would appreciate knowing that there's a option to either connect with the IT people. But I mean, you've given us their number. It just would probably be more efficient for them if they could just set up a couple of meetings
Yeah.
that rather than have all of us calling individually, you know?
Mhm. Yep.
Well, and even if you get logged in prior to getting the core or the tech support meeting set up, could also just be helpful to ask them any questions, anything
Yeah, that's true.
weird and
Do you know how to automatically change VMware to open up in Google Chrome and not Internet Explorer? Do you know how to do that? If you don't know how to do that on your computer, then it's not gonna work, maybe.
Does everyone have Google Chrome?
Yeah.
Program.
Yeah.
Our default is Internet Explorer because of the version of all scripts that we're on. We're getting an upgrade in May, and then that will change, and our default will be Chrome.
Oh, okay.
So all scripts is our challenge with our internet browser right now. Because it
there's
won't
always
function
one thing
in-
that challenges it.
Only one?
Oh, true. Okay. At least one.
Mm-mm-mm.
So do we have our takeaways for everybody? You're gonna email them, and then we're gonna have a couple different Zoom options. They also have the IT number if they want to call directly, and then we'll have our IT people help get everybody in the first time if they're not able to get in.
Yes. Yep. So I will email out. Everybody will also, as soon as that is, I can figure out, times where we can have both a Horizon and Core representative available. I will send out meeting invites for that. And then you'll also be getting a meeting invite from me for the weekly PMRR meetings, probably yet today.
That sounds good.
Perfect.
Any
Excellent.
questions, concerns, comments, anything?
Nope, very informative. Thank you.
Thank you.
Thank you.
Awesome.
Thanks everyone for your
It was
It was
attention.
great meeting the rest of everybody, and I look forward to working with you all.
You too. Thanks again. Have a good rest of your weekend.
You too. Thank you, everybody.
Yep.